In this evening's webinar, it's going to be approximately 1 hour. At the end, we'll save some time for answering questions. And if you have any questions as we go, you can type them in the chat, and then we'll make sure to address them later. So today we're going to be talking about chronic pain and the science behind it. And I was looking up numbers, so I was like, how many people do have chronic pain? And Morgan and I were talking about it, and she was like, I don't know, maybe 40%, because we feel like it's kind of what we work with all day. But the numbers, actually, the latest stat that we have is from 2023. And the data is that approximately 1 out of 4 adults in the US experienced chronic pain in 2023. So definitely a large population and something that's really important to address, because there are benefits to understanding chronic pain and knowing what your options are to manage it. So let's go ahead down. So this is me. Dr. Magda Mitaszka. I grew up in Massachusetts, but I kind of consider Austin home. I've been here for a little over 10 years now, and I have a doctorate of physical therapy from Texas State in 2021. So I've been practicing PT for about 5 years now, and I've been at Opal for 1 year, and I also have a side job doing hospital-based PT. I'm really passionate about pain science education. We're starting to talk about more. So it really early 2000s that providers started to even talk to about what is pain, how is it processed, and how does that empower us to use tools to change the way that our pain experience is. And in the clinic, we really see a mix. Like when I see somebody with chronic pain, a lot of times I'll ask, like, what do you know about chronic pain? Or what do you know about the way that pain is communicated through the body? And some people are like, oh, I know this. I listen to podcasts all the time. I've taken courses on it. Some people know a lot. And other people are really like, I don't really know anything. Like, doesn't the body just tell the brain when it's in pain? So there really is a big opportunity to educate on pain science. And then last little tidbit about me is that my favorite ways to move my body are tennis, weightlifting, and walking. And then here we have some photos of our clinic, Opal Movement Therapy. So Texas, which is just north of Austin. And right there, we have everything we need right in there in a gym. So we have access. It gives us the opportunity to be able to simulate any sport that somebody is wanting to work on. We have the equipment and space in order to work on that. And at Opal Movement Therapy, we do a combination of manual therapy and then rehab exercises, as well as working more towards sports performance. All right, so we are going to get right into it, and we're going to compare 2 pain theories. One is a very old historic one that's kind of funny because the way we see pain now, the old model. So the old model, Cartesian model, I had to look this up. It's actually from the 1600s. So the way that the old model worked was that if there was, use flame as an example because it's easy. If there was a flame input at somebody's foot, then the message just went up to the brain and it said pain. It was that easy. It was just tissue injury equals pain, that's it. And that the level of pain was equal to the level of tissue damage. So it was just kind of one-sided like that, but hey, it was the 1600s. I mean, they only knew so much. So now we have this new biopsychosocial model, and this model has emerged since 1977. And this model includes all of the other factors that we can start to see in this picture here, where it lists past experiences, mood, attention, expectation. So it's very complex, but it is accurate in how the pain experience goes for people who are experiencing chronic pain. I found a kind of a nice sentence about this model that I connected with. So it says that the biopsychosocial model hypothesized that pain is a result of complex interactions between biological, psychological, and sociological factors. And any theory which fails to include all of these three constructs of pain is failing to provide an accurate explanation for why an individual is experiencing pain. And these factors are listed on a later slide, but I think it's a little bit relevant to talk about now, just those couple of different factors. So psychological factors that affect pain include psychological. So we have mood, depression, anxiety, perception, expectations, and fear are some examples. And then just to dive further into one, we talk about perception. So somebody's perception, they might sprain their ankle, never hurt themselves before, don't know very much about the human body, and they might think, oh my God, this is terrible. Like, what am I going to do? I can't walk. I can't do the things that I want to do. Versus the same exact tissue injury, somebody else might sprain their ankle who does have some sort of experience with rehab, or maybe their roommate's a physical therapist or something. And it might just be something like, oh, yeah, I'm gonna manage this. This is tolerable. And their pain experience will be very different because their perception of the injury is very different. So that's just one example. There are a lot. The next factors would be sociological. And that talks about social support, cultural norms. Does somebody have health insurance? Are there language barriers? And an example of cultural norms would be, luckily this is kind of going away, but we all used to hear about the no pain, no gain. And that was, we can say, a cultural norm where people just push through. And also kind of the manly same thing, like suck it up. That is also a cultural norm. And that is something that affects the way that pain is experienced. If somebody just sucks it up and pushes through pain, then that's something that they're going to be having to kind of deal with later as a factor influencing their pain. And then lastly, and again, all these are listed later, the last factor would be biological, which we talk about tissue injury, is finally in there as one of the factors, but also genetics, immune function, hormones, and then also the effects of lifestyle factors, such as diet, activity level, and then sleep, smoking. So tons and tons of factors go into pain in this new biopsychosocial model, relatively new, but that is what we're working with today. Okay. So here, the tissue to the brain. We know that the brain is actually what's going to decide pain. So instead we say it's danger. So we can use that flame example again. I feel the flame come to my foot, and the message that's going to travel up to my spinal cord and brain is just going to say danger. And at that point, the spinal cord and the brain are going to make decisions on, what do we do? Do we send pain for this? And then they'll store that information for later. So pretty much when we can use the fire again. The spinal cord can also make decisions, not just the brain. So flame felt at the foot, and then the spinal cord through a reflex arc is going to right away have you move the limb away from the flame. And then the message will also then go up to the brain, and the brain will send pain signals. And then it'll also, again, store that because the brain definitely remembers pain, which we'll talk about later. And then again, just talking about here, the brain produces a unique pain experience. So some of those factors we talked about previously, biological, socioeconomical, all of those factors are going to create a unique pain experience. So just because two people have the same exact tissue injury, their pain experience will be very different depending on all of these factors. And again, if anyone's starting to have any questions, and you can start to type them in the chat now so that you don't forget, and then we'll circle back to them later. Okay. So now we're going to talk about how the nervous system adapts with acute and chronic pain. So with acute pain, which is pain lasting shorter than 3 months, and we can think about a low-grade ankle sprain. So with this, these changes are normal and they're protective. So I also want to comment on how pain is not always a bad or negative thing. Of course, with chronic pain, it can be very limiting, but pain is actually necessary to live our lives, right? So we need to know that our hand is touching fire so we can move it and not hurt ourselves. Same even if we didn't feel an ankle sprain and just kept going, playing a sport, that's when we would have much more severe injuries. So these are adaptations with both acute and chronic pain, which are normal and protective with acute pain. So here we can talk about as we have more dangerous stimulus going in, the spinal cord is going to just get better at sending signals to the brain. So as more stimulus is tagged as dangerous, the spinal cord is kind of like, all right, we keep getting all of these danger messages. We have to keep sending all of them up. Let's just keep sending it. Like, we know the drill. So next thing you know, more and more signals that maybe previously wouldn't have warranted making it up to the brain. Now the spinal cord's like, all right, just send it, just send it. So these alarm bells are going off and the spinal cord is getting really good at sending them up to the brain. So when we talk about different ways that we get sensitive with these tissues, there's two terms. One is hyperalgesia. So that would be if something didn't hurt, things that usually hurt now are going to hurt more. So a pinprick, yes, it's sharp. Oh, I'm sorry, I'm reading this wrong. So hyperalgesia, things that usually hurt are going to hurt more. So a pinprick should hurt a little bit, but now it might feel like it is this debilitating sensation. And then allodynia is when something didn't hurt and now it does. So people who have very, very sensitized nervous systems, even somebody touching them with their different hand or with a cotton swab can feel very, very sharp and intense. I think that's good here. So yeah, again, just a comment with acute pain, this is normal and protective. And then with chronic continues, that's when things can really be limiting. So talking about chronic pain here, we generalize, of course it can be different, but we generalize when a condition persists for greater than 3 months that it's going to be chronic. And pretty much it's going to be a scale weighing of how dangerous versus how safe does your nervous system feel. So if we have things that, a loving and supporting family, we slept really good last night, work has been great, not worried about it, those are all safe factors. And then dangerous factors, maybe you just moved to a new city and don't know anybody, you hate your job, you're late on your bills. These things now are going to make you feel like you're more in danger, and it'll increase that pain response. And the brain remembers pain. And I have a couple of little anecdotes that can help us understand that. So one of them is going to be talking about demolition derby drivers. So I don't know if y'all have ever been to a demolition derby. I've been to one in Texas. And people, it's literally their job or just a big hobby that they're going to drive cars around and crash them. And it's fun, it's exciting. And their pain experience is going to be very, very different from somebody who's in a true car accident. So somebody in a true car accident, maybe their car is ruined, they're late to work, they have to get a rental for days, they have a headache, whiplash, their whole world can be flipped upside down. Meanwhile, a demolition derby driver is just gonna go home and be like, another day at the office. So same exact mechanism here, but the expectation and perception of what's going on is very different. The next story is about, Dr. Lorimer Moseley. He's a pretty famous pain scientist, expert, and researcher. He's Australian, he's hilarious. Some of y'all may have heard some of his videos online, but he has this story that he tells, I think it's in a TED Talk, that he's on a hike in Australia and he feels something at his leg and he's like, oh, it's just a blade of grass, I'm good. Keeps walking on his hike. And later he realizes he was actually bit by a venomous snake and that it was very serious. And yep, so that happens. And he's like, okay, so brain is storing this information. And then it's about 6 months later, he's on the same hike and going about his hike, and then an actual blade of grass touches his leg, and he just has the most severe piercing pain because his brain was remembering his previous experience and decided, like, we must protect, like, let's get you out of here, move your leg out of the way, go tend to this, when it was literally a blade of grass. So yeah, and he's hilarious. We cite him at the end of this slideshow, but he has some really good information. When I was a student, I had a patient who had a really like nasty leg fracture in a motorcycle accident. And I think this was probably like 4 months after his accident. And we're going through PT, and he like comes in and he's like, "Oh my God, I re-broke my leg." And I was like, "Oh no, what happened?" And he said, "I was at a wedding and I was dancing and I fell and I re-broke my leg." And I'm a student and I'm just kind of like looking around. I'm like, where is my clinical instructor right now? Like, I don't know what to do. And I'm like, okay, they taught us these rules that if somebody has tenderness in spots X, Y, and Z, and if somebody can't bear weight for 4 steps, then you need to send them out to image for a fracture. So I'm like, okay, I got this. Let me take them through these steps. I take them through the steps and they're all positive. And I was like, oh my God. So I go and grab my clinical instructor and I'm like, hey, like, he thinks that he re-broke his leg. And my boss literally like looks at him and goes, watch them take like a step and maybe touches something. And he was like, he's fine. And I was like, what? And I was freaking out as much as the patient. And my CI, a clinical instructor, he was like, the brain remembers pain. He landed gently right where he broke his leg, and his brain remembered that. So it wanted to make him protect it. And that's all. He was like, continue onward. And I was like, okay. And the patient comes in 2 days later and he was fine. So just another example. I have one more that I actually think is really interesting. I had a patient who they were living half time in Austin and half time in Costa Rica, and they were opening a whole wellness retreat center in Costa Rica. They loved being there. They were a yoga instructor, and they only had pain when they were in Austin, Texas. And I was like, that's interesting. So they come in to see me in Austin, and I'm doing my whole assessment. And when I'm just looking at her movement, her joint mobility, her strength, her nerve mobility, I'm like, I'm not really seeing what's the pain generating source. And she also moved very well, understood her body, understood relaxation strategies. And then she emailed me a few weeks later and she was like, I just moved to Costa Rica full time. Here's the link to my wellness center if you ever want to come. She was like, I'm pain free. And I was like, all right. So just another example how her tissues of her body did not change between Austin and Costa Rica, but all those other factors that we talk about obviously did. Okay, that was a lot, but hopefully y'all are still with me. All right, so I've already commented on this with the evidence of danger versus evidence of safety. And again, it's literally going to be a sliding scale. And these are some of these things that we've heard before that hopefully physicians, they're getting a little better, but sometimes too, people will come in and say, yeah, I had my knee x-rayed and the doctor said it's bone on bone. It's the worst he's ever seen. And those are things that, of course, is going to incite danger in somebody. And hopefully now people are realizing more how these things, we have to be careful with our choice of words because they are truly going to make an impact on pain levels. So further here, like expectation and perception. So you get a diagnosis that you don't understand, and maybe you got this diagnosis at a clinic, but you don't have health insurance to go to any type of therapy. Maybe English is your second language. So now, again, you just don't have realistic expectations of what the process is going to be. On the other side, we have evidence of safety. So love to say this to people too. Usually it's true, just kidding. We'll say, we treat this all the time and we have really good outcomes. So it's just kind of laying out that plan for people so that they know, like, okay, this person knows how we're going to manage this. They've worked with other people who have been able to come out of this with positive outcomes. It makes people feel safe. Therefore, it's going to lead to decreased pain. Further, loving support is major. And at my job in the hospital, you always know some rooms you go into and somebody's alone. They don't know anything that's going on. And other rooms you go into, they're surrounded by family. There's balloons, there's flowers, there's a family member taking notes who knows every single thing about the patient. And I always make sure that I say before I leave the room, I'm like, you are going to do well because of this support system that you have. And I think that previously that might have been something that people were like, oh, that's just foo-foo. Like, what do you mean having loving support is going to change the way you feel pain? But now we have evidence that all of this is actually true. So it's not just something, be optimistic and you'll be better now, which is pretty cool. Right. So the immune system, which always find its way into conversations. So when we start to have pain that's now chronic, the immune system is going to get involved. So and there's that again. So cortisol, which we know we can have with stress, can directly activate the danger pathways, and then stress response is heightened further. So typical stressors, we know work, money, family, anxiety, sleep. So all of these things then are it's like a cycle. It's like you're feeling stressed, you have high cortisol, and then you are not sleeping as well and not eating as well, not feeling good, which then now are going to have more cortisol and more pain. So yeah, so it's super unfortunate, but it's also good to know and to realize that the immune system is also going to get involved here. And this is going to be more relevant in chronic pain versus acute pain. So for example, if I have somebody in the clinic who I'm seeing for a acute knee pain that they maybe had a meniscus injury 2 weeks ago, and if they're talking about their pain and asking for suggestions, my first question isn't going to be, well, how's stress when it happened 2 weeks ago? However, somebody who's had back pain for 5 years and they're having a really stressful week with family, with work, then that definitely is warranted and like probably a necessary conversation to have. Okay. So now we're going to talk about central sensitization. So this is true of chronic pain. So when I think that they have central sensitization, because this is the kind of hall happens. So pretty much the pathways that are going to calm down pain are going to malfunction, and the pathways that turn up pain will get enhanced. So the brain is able, from top-down modulation, the brain is able to calm down pain, but that system is going to malfunction once we're in a central sensitization. And then when we continue to do things that are painful when the system is so sensitized, then that's going to actually increase the response. So it's not something that we recommend pushing through pain by any means, because then the alarms are already ringing and going off and sending signals easier and faster than before. And then we're feeding into that system. If every time you do a squat, you feel your very severe back pain and it's like, oh, I'm just going to push through it. What's actually happening is that those signals are now just going to go faster and faster and just keep on sending. So that's also why it's really important to have this type of education to know that, okay, I need to listen to that so I can try to calm down my system and to do the opposite. And again, here, the very important concept that pain experience is not necessarily proportionate to tissue damage. And I meant to mention earlier, but this will actually be a good spot to mention it too. These are kind of classic examples, but just reminders of tissue damage not being equal to pain. So somebody can get a paper cut, very mild tissue damage, and it can feel like this severe pain that they don't even know what to do with themselves, right? We all know those people. And then somebody can be a professional basketball player. They can tear their Achilles during a play, and they can still walk over to the foul shot line and take their foul shots and act like nothing went wrong. So just it's important to think about examples like that so we can actually be like, oh yeah, I actually know that tissue damage does not equal amount of pain. Okay. So again, which is the hallmark of chronic pain. Here are some of the symptoms, and this is not something that if you are sensitized, you're going to have all of these, right? But this is a list of all of the ones that we kind of see. So sensitivity to bright light, which is usually I see that with people who are like very sensitized. It's more like to like pressure to people touching them. That is, we see a little more commonly. And that then leads into exercise and hands-on therapy being a stressor. So some people are so sensitized that we try to get their joints and nerves moving with manual therapy, and it just ends up poking the bear. So at that point, it's just not appropriate. And there's sleep again. So luckily, we all now, as a society, are learning and accepting that sleep is really important, and it can't just be diet and exercise to be healthy. It has to be three pillars of diet, exercise, and sleep. So with chronic pain and central sensitization, that's when we can have more sleep disturbances, and when we kind of wake up and just feel like did I even just sleep? Just kind of feel groggy. So that's one of the signs of central sensitization. Also, increased unrelated symptoms. So this one is kind of interesting too, where somebody had let's say an old shoulder pain, and then they're coming in and we're working on their hip, and they're like, yeah, I started feeling my shoulder the other day. And that one, I like the analogy of me in my house. And if I drop a plate and I scream, maybe my neighbor next door will hear me, and that's it. So just something mild happens. My scream doesn't go that far. But if the house is on fire, I'm going to be screaming bloody murder, and the whole neighborhood is going to hear me. So the alarm bells are going to just be louder, and that's when the neighbors are going to be coming out. So the neighbor, being that old shoulder pain, is going to come out and be like, hey, what are these alarm bells? What's going on? So all of the other areas that our brain, again, remembers pain, they're going to be coming out and checking out what's going on. So central sensitization, many of us have heard of fibromyalgia, chronic fatigue syndrome. So that is very common to experience these symptoms with those diagnoses. And then more about what we would see in physical therapy. I would say that I see it the most with chronic low back pain, but it's also common with headaches, osteoarthritis, whiplash, TMJ, and rheumatoid arthritis. Another example would be presence of a local pain condition prior to trauma or injury. So an example would be I had back pain already, and then I get into a car accident. So again, keep bringing up those alarm bells, but the alarm bells are ringing, and now they're ringing even louder and louder. So old injuries are also going to be thrown into that whole system of increased alarm bell ringing, increased signals firing to the brain. Okay. This is me and Dr. Morgan were classmates in physical therapy school, and our neuro professor, he loved this picture. He loved this picture, and he loved the phrase smudging of the homunculus. And Morgan and I always just pull it out. So the homunculus, which it's pretty much a motor map in our brain. Like this right here is actually literally part of the brain, and different parts of it, those areas relate to different body parts. And the bigger that part of the brain, it's something that we need to have a lot of input to and from. So for example, we have to have very good sensation and function with our hands for all the things we do. So that's why that area of the homunculus is going to be bigger. When we move a body part, then it's like the homunculus and the map is getting exercised. It's keeping those connections sharp and crisp and focused, keeping us coordinated and moving well. And any of us who have had pain know that when we're experiencing pain, it makes movement a little harder. So if there's a part of our body that we haven't moved for a while, then the body part on the homunculus becomes smudged. That's also connects to when somebody has an amputation. that part of their brain doesn't just go away because their, let's say, below their knee has not been amputated. That part of the homunculus is still present. So that explains the phantom limb pain sensations. So again, with the map, we want to make sure that we're able to keep moving areas that are injured so that the map doesn't get blurry. So examples would be, yes, it's painful to exercise things that hurt, but that's why it's important to work with a movement specialist or physical therapist who can help you find ways to move it that isn't going to increase your pain, so we can keep that map nice and crisp, because otherwise our movements can start to get a little uncoordinated and rigid. So there's the homunculus. I hope somebody uses that phrase tomorrow. Okay. Bear with me getting through it, y'all. I know it's a lot. Okay, there's me doing a remote call and loving my life. So pain science education, which y'all have made it now through 30 minutes of pain science education. It's very important because it teaches us what is going on and helps us to reconceptualize it. Because understanding this is kind of like, okay, you told me all of these things that are going on, and what am I supposed to do about it? The goal is for you to be able to realize, okay, all of these factors are going into it, and the brain is what is communicating pain to my tissues. And just because I have pain of this magnitude does not mean that my level of tissue injury is equal to that. So it's really more about reconceptualizing, because at the end of the day, your pain is real. So this doesn't mean that it's all in your head or anything like that, because pain, the definition is a subjective experience that somebody is feeling. So what you are feeling is what you are feeling, period. That doesn't mean that what you are feeling means that your level of tissue injury is here. And that's a very important thing to grasp. And somebody who tells you that, oh, you're fine, your pain's in your head, you just need to go relax, that's going to increase those danger factors that we talked about before, where you feel unheard, you don't even know what to expect anymore, and now the pain levels are actually going to increase. But instead, it's important to accept, like, this is my pain, what I'm feeling is what I'm feeling, but like, maybe I'm feeling it for this way, this reason, instead of because of my tissues. So an example, I've had back pain for 5 years, and I wake up and I'm like, oh, like this feels cranky. Instead of being like, what did I do? Did I sprain my back? If I'm like, I don't feel great, I'm going to do my mobility and I'm going to modify it. And then also like, yeah, work's been kind of stressful. It's really nice out today. I'm going to go on a walk. I'm going to call my friend who I love a lot, and we're going to go on a walk together. And that's my plan for the day. So that approach is going to get my body moving, and it's going to also, I'm going to attempt to calm down my nervous system with reconceptualizing what's going on, spending time with a loved one, and getting some gentle movement. Research shows that pain science education is most effective in smaller chunks. So even some of the things that we've talked about here are pretty dense. And if I spent the first session of physical therapy with somebody going over this PowerPoint, I think that they would leave and never come back. So it's more about smaller chunks spread out over time. Oftentimes, when I start to realize that chronic pain and central sensitization are a part of somebody's pain experience, I usually start with, like, how much do you know about the way that pain is processed? Just start with an easy question. And I may just on that first time mention, like actually, pain is an output from the brain, and level of pain is not equal to level of tissue injury. I usually kind of just like start with that and let it mull over. And then later I'll kind of bring it up more and just be like, like, did you think about that more? Do you have any questions about it? And then of course, when somebody just comes in and they're all stressed out and their pain's higher, then that's a really good time to talk about, okay, like, have you been doing anything lately that's increased your stress? What are your stress management tools? And just sometimes your exercise isn't going to be doing squats and hip hinges. It's going to be going out in nature on a walk, because that's actually what your body needs more than just trying to manual therapy and exercise your way out of chronic pain. I think that's all I want to say about that. Okay. So key reminders, and I think I've just been nailing this one on the head. So y'all heard this one enough that pain does not always equal tissue damage. So there's so many things that come in between that are going to dictate the level of pain. And this one we talked about too with a couple of the examples of different patients, that each recurrence of pain does not necessarily mean you have re-injured that tissue. So like my former patient who was like, I broke my leg again. And I was like, oh my God, maybe he did. And my clinical instructor was like, he's fine. His brain just remembered it and was trying to protect him. Next reminder is that the nervous system does better with gradual increases in activity or exercise. So with chronic pain, it's very important to listen to the pain and to find ways to move that don't increase it. So when we talked about the alarm bells and the signals firing up through the spinal cord to the brain, if every single time I do a squat, I have my personal chronic pain, and I'm just like, oh, I'm just going to squat through it, that's actually definitely highly not indicated to do, because now those signals that we know the alarms are going off, they're going to go off even more and more. So it's really about finding ways, whether you can do it by yourself, by doing a smaller range of motion in your activities, or again, finding a movement specialist to find ways to move that part of your body without pain. It's very, very important. And then slowly your body's like, okay, like let's counteract some of these danger signals. Let's do, okay, great. I did squats for 2 weeks with decreased range of motion, didn't go super deep, but there was no pain. Great. Now we're starting to get some positive input into the nervous system. And next thing you know, those alarm bells are slowing down their sending. They're not sending as quickly, and they're not sending messages that go all the way down the street where the neighbors, like the old injuries, are popping out to see what's going on. So it's a process, and yes, it takes time, but very important to do it gradually and to find things that don't cause pain, and then you just slowly progress. This is really important, the last comment here, and I think we've been talking about this more in the clinic to our patients as well, is that if you have a flare-up, it's okay. So again, if you have a flare-up of back pain or wherever your personal chronic pain is, it doesn't mean that you've re-injured the tissues by any means. So the nervous system is so sensitive. A lot of things, all these factors you talked into, go into the pain experience. So if you have a flare-up, it's about having your tools in your toolkit and using them versus thinking that you've re-injured yourself. Okay. And this here, we've already talked about, I ended up mentioning it earlier, but just so we have it in one place, here are all of the, or not all, but many of the factors that go into pain. And it's interesting because really tissue injury, what we used to think tissue injury was all that mattered into pain, tissue injury would just be one of these many. And looking at this list, I personally know that plenty of these factors I can relate with, and I'm imagining that some of you can too. So a lot of these factors, some are modifiable, some are not, but there are so many factors that go into our pain experience. Okay. Chronic pain. So good for y'all. You've learned more about how pain works, and is that you can reconceptualize your pain. Tip number 2 is to get regular aerobic exercise. So sometimes our clients have big flare-ups and they're like, I don't know what to do. I need to get my yayas out. I need to move my body. That's when even walking, biking, swimming, things that are more gentle are still going to be really good for your body, because it's going to get blood flow and oxygen through your body. And we love this number here because it's so interesting that the nervous system makes up 2% of your body mass, but it consumes 20% of the oxygen going to your tissues. So we just got to go out there, get some blood flow through our body, whatever way is comfortable and whatever one you enjoy doing. Oh, and I can't miss this point. It also helps exercise the body map in your brain to reduce smudging of the homunculus, our favorite. And again, we all know now how important sleep is, but instead of worrying, like, do I need to go to get an adjustment tomorrow? I need to go get a massage. Like, maybe let's think about things that you have control of. Like, what time did you go to bed last night? Were you scrolling before bed? Were you eating a big meal? And how many drinks did you have before bed? Things like this are things that are in our control daily, and they're good places to start. And then stress relief is definitely something that we talk about with our clients, and it looks different for everybody. And for some people, it's deep breathing, and some people, it's just literally sitting outside and listening to nature. It doesn't matter what it is. Whatever you feel like you can do to relieve stress, to calm down your nervous system, is really important to have your personal stress relief. Lastly, just to set goals for, again, having optimism, which we know is important so we can feel safe and to have something to work towards. So even starting with small steps. So what is one thing that I can maybe in the next couple of weeks accomplish that is a small step on the way to a bigger goal? Okay. These are some resources. The first one is Lorimer Mosley, and he's the one that had the funny Australian guy who had that story about being bit by a snake and then thinking it was still a snake when it wasn't. So these are just some resources here. References. Okay, so let's see any questions in the chat. Thank you guys for participating in my first webinar. Let's see some questions. So my spinal cord just hates me. That's hilarious. Let's see. How can someone with fibromyalgia tell the difference between normal soreness and a flare-up? Okay, so that is a really good question. So when we're talking about trying to conceptualize our pain, it also matters about where the pain is. So if you have pain all over, then it's also trying to move in ways that aren't going to increase the pain in that area. But if it's like if your fibromyalgia pain is just in a few spots, we don't want that sensation to increase as we move. But if your symptoms are just, let's say, in your legs, and if you're moving your body and you start to feel pain in your back or your arms, like, of course, we don't want you to have pain, but experiencing pain in different areas is not going to set off the alarm bells in the areas of your pain, if that makes sense. And let me know if I didn't answer that correctly. Moves with shoes is back. How do I get better sleep to help my back pain if my back pain is bad at night? That is a very good question. So a lot of our clients with back pain do have trouble sleeping, and sleep is really important. So it's a multifaceted approach for sure. Sometimes that means making sure you do your mobility before bed, because once we're sleeping, our tissues aren't moving as much, right? And we know that they need to get oxygen and the joints need to stay lubricated with movement. So a lot of people have like a little quick evening mobility routine. The good thing is a lot of them can already be done right in bed too, right before we fall asleep. So an evening mobility routine is great. And then also checking in on your sleep routine too, just making sure that you're trying to go to bed at the same time every night, not eating or drinking alcohol before bed. And if that's something that needs to be further investigated, then we talk about that with our clients all the time. So talking to a physical therapist about it. Okay. And then how do we exercise the body map to reduce smudging? So to reduce smudging, we want to make sure that we're moving the part of the body that we previously had not been moving, which led to the smudging. And that starts with the most gentle form possible, right? So that could be something as simple as doing lying down exercises or assisted exercises. Like if y'all have ever done total gym exercises in the clinic, which are doing squats at reduced body weight, and you can make the body weight be very, very reduced. So it's finding a gentle way with no symptoms to move that body part, even if it's just range of motion of that body part, instead of doing it with weight or resistance. Okay, and then can you go back to resource so I can take a picture? Absolutely. Okay. And building a mobility plan for chronic low back pain. So all of our patients with chronic low back pain have a mobility routine. I have a mobility routine as well. I don't even have pain. It's just things that I want to keep my body moving, and these things that I've had tightness with before, and they feel good, they're quick, they're easy, they're just part of my day. So absolutely, I think anybody with chronic low back pain should have a mobility routine.
There's a YouTube video that we can drop.
And we will drop in the comments. We have a YouTube video already made by Dr. Morgan. That's a gentle mobility routine for low back pain. So we'll drop it in the comments. And then, why do my knees always hurt with exercise, even when scans show nothing serious? That's a good question. So for pain, right? So again, tissue injury does not equal pain, right? So there could be something going on that isn't necessarily structural, but functional. So everything looks good tissue-wise, but sometimes the way that functionally your body is supporting your knee with your muscles and the way that you load your body can be overstressing the knee. And furthermore, I mean, this could be a whole deep dive on its own, but also things like joint dysfunctions, or when joints aren't moving as well as they should, are not going to show up on imaging. Okay. All right, one last second for questions. And here too on the slides, we have just kind of like ways to contact us. This is the team, me, Dr. all over social media, and we love questions to communicate. We take requests on Instagram and on YouTube. So if you have any questions later about the content or about anything else, we'd love to hear it. We love talking with you guys. And we also do free discovery calls. So on our website, there's a link to do a discovery call to see if you would be appropriate to work with us, if it would be a good fit on both ends. At Opal Movement Therapy, we also do remote movement coaching. So this is appropriate for clients with no to low levels of pain who more so want to get a mobility routine, get a strength training routine, and just learn how to move better for longevity. And this is me with a patient in our recent photo shoot. All right. Any other questions? We're about to drop that link into the chat. Let's see. Yeah. Any other questions? Oh, perfect. Okay. We got the link dropped in there. All right. Awesome. Dr. Morgan was just stressing trying to find the link, but our amazing admin, Natalie, took care of it. Love you, Natalie. All right, guys. Well, thank you so much for participating in my first webinar. And again, we will have these slides and the recording of the presentation to share. But again, I just want to encourage everybody to, if you are experiencing chronic pain, hopefully, and look back at this later, it was a lot. But again, the big takeaways, pain is an output that your brain sends out to your tissues based on many factors in life, and that level of pain is not equal to level of tissue injury. So just starting with those two things is fabulous. So you can start to reconceptualize your pain. Awesome. Okay. Thank you, guys.